iPrEx trial.
So it's a pleasure to be here today. We're going from the qualitative to the quantitative. So we know that PrEP works. We know that adherence matters. But in terms of advising potential PrEP users, they want more specific guidance about what types of dosing patterns are likely to lead to protection. As Damon can attest, a very common question that people encounter is, how many doses of Truvada do I need to take before I can expect protection? People want answers to these questions that are customized to their circumstances. And this is interesting. Am I switching? I didn't do that. Customized to their circumstances. And a particular part of that matters is the possible route of HIV exposure for that person. Now, there is some reason to believe that the answers to those questions about the relationship between dosing and protection may matter by the route of exposure. If we review the modified intent to treat results across the PrEP trials that have been done, grouped by the most likely exposure site, we see strong evidence of protection in rectally exposed individuals. iPrEx has less of a signal there, but as I'll get to later, we think we have a good idea about the type of dosing required for protection for these types of individuals. When we look at vaginally exposed individuals, we see two very good signals, two null signals, and I think there we don't have as clear an understanding of the role that adherence through dosing, through drug levels to protection. We don't have a sense of that story quite yet. But we have some important insights from small pharmacokinetic studies. Now, these studies enroll HIV-negative individuals under very controlled circumstances. They've dosed them with Truvada or with tenofovir, and they've studied the levels of intracellular drug, tenofovir diphosphate, or emtricitabine triphosphate, in the blood through PBMCs, in the rectal tissue, and in the vaginal tissue. And an observation first made by Angela Kashuba's group was it appears that tenofovir diphosphate concentrates in the rectal tissue and reaches levels that may be 10 to 100-fold higher than seen in the vaginal tissue. Additional detail was provided by a study done by Peter Anderson's lab at the University of Colorado, Denver, which dosed a group of HIV-negative individuals with 30 days of Truvada and looked at levels in cervical cells of tenofovir diphosphate and in rectal cells. So we see higher levels achieved of tenofovir diphosphate in the rectum compared to the cervix, and a suggestion, and it's based on a very small number of points. You can see them on this graph. A suggestion that the onset of the time to reaching peak levels is slower in the vaginal tissue. What's difficult about interpreting results like this is we don't totally understand how much drug there needs to be, where it needs to be, and when it needs to be there. We've tried to do some work with the iPrEx data to address these questions. We used data from the iPrEx trial where we tested levels of tenofovir biphosphate in the peripheral blood mononuclear cells. We tested those who became HIV infected during the trial. 93% of those individuals had no detectable levels of tenofovir diphosphate, as well as a series of matched controls. Based on that comparison, using a regression model, we could define levels of tenofovir diphosphate in the PBMCs associated with 90%, 75%, and 99% protection. We were fortunate to engage Albert Liu's group, who had done a directly observed therapy study of levels of tenofovir diphosphate in people taking 2, 4, and 7 pills per week of tenofovir, and able to align these levels. And these show that among daily dosers, all of them reach levels above an EC90 or 90% protection, that there's evidence of protective levels even in people taking 2 doses per week, and nearly half of those taking 4 pills per week have levels above the EC99. This suggests in a rectally exposed population like iPrEx that there would be substantial forgiveness for missed doses. Corroboration of this came at first in the form of the iPrEx Olay study. That was an open label follow-on to the iPrEx trial in a group of rectally exposed individuals. We tested drug levels in a case cohort fashion using tenofovir phosphate from red blood cells and aligning those with dosing based on PK modeling. We had the observation again that protection may begin as low as 2 to 3 pills per week, and we observed no seroconverters during periods consistent with at least 4 pills per week. I don't know why it keeps doing that. So I would say to some extent additional corroboration came in the form of the PROUD and iPrEx results this year. So I'd like to talk about this issue of starting and stopping. So we're going to apply what we've learned from the iPrEx protective concentrations to the cell PrEP study conducted by Peter Anderson's group. That dosed a diverse group of HIV-negative individuals, studied them for 60 days, 30 days on Truvada, a 30-day washout after that, looked at levels of tenofovir phosphate and emtricitabine triphosphate in cervical and rectal cells, as well as PBMCs. And when we look at those PBMC levels and align them with the concentration risk relationship observed in the iPrEx study, we get the following results. We see that within 2 doses, half of people approach the EC90, and we would expect, based on proportional drug levels quoted by Jean-Michel as well as HPTN 066, that 2 pills taken on one day should produce this same relationship, and that 2 additional days of dosing produces levels well above the IC90, as well as highly protective concentrations. This study found after 30 days of dosing, watching those levels as they wash out, that levels remained above the IC90 for just about a week. That's after a period of 30 days of dosing. I think these results are highly concordant with what's been observed in the iPrEx study. And the suggestion would be, I think many people have noted that that was in a highly exposed population that was taking as many as 16 pills per week. But the basis of cell PrEP suggests that even from a cold start, it's very likely that 4 pills produces a protective concentration. Now, looping this back to what we've seen in ADAPT. So in the ADAPT study, studied 3 different populations. And what I find striking is that there was a population, those in Bangkok, that took very well to event-driven dosing. They had high coverage of their sex act with event-driven dosing. We see in the Cape Town population that there was clearly much less effective use of PrEP in those employing event-driven dosing compared to daily dosing. And to my mind, this opens up a real disparity in what we would recommend in terms of event-driven dosing. For vaginally exposed individuals, we have triple cautions. We have absence of clinical trial data. We have drug level data, which is not suggestive that this is likely to be effective. And we have at least one population that's been studied in which it was not as well adhered to as a daily type regimen. Meanwhile, in a rectally exposed population, we've seen 2 populations now, in Bangkok as well as the iPrEx population, that effectively adhered to that regimen. We believe it's biologically effective because we believe in randomized clinical trials. And the drug level data is highly supportive of it as well. So I'd just like to point out that it's an unfortunate thing that we're able to say so much about a rectally exposed population. We badly need a surrogate of protection in vaginally exposed individuals as well. I'd like to thank my collaborators in the iPrEx study, as well as Peter Anderson's group for all the work they did to collect the data I'm discussing.